Sure.
So welcome everyone. Today is session number 4 of the ECHO of Perinatal Mental Health. Before we start, just some introductions. I feel we are starting to know each other already, but I still will ask people to say their names and a little bit about them. So if there are new people or people that don't remember, so we can just know who we are. So Amber and Mary are part of Mountain Pacific. They're helping us to have this ECHO in place. And why don't we start with Sarah Beth?
Hi, everyone. My name is Sarah Beth Upson. I work for Montana Medicaid based in Helena. And my title is the Perinatal Behavioral Health Initiative Program Officer. So I oversee a HRSA grant that covers the Meadowlark Initiative and also the PRISM for Moms teleconsultation line.
Thank you. So I'll go how I have you in my screen. Okay, so maybe Jenna, can you tell us about you? We know about your baby.
Yeah, this is Miss Ada. I am a private practice clinician in Whitefish. And I also work part-time with Alticare in the school systems at Smith Valley School.
Thank you. What about you, Mandy?
Hey, I'm Mandy. I'm the care coordinator here at Midwifery and Women's Center in St. V's.
Thank you. What about you, Casey?
I'm Cassie, and I'm a student women health nurse practitioner, and I'm doing my dissertation work on identifying substance use in pregnancy.
Yeah, that's right. I remember. Hi, Gavin. Can you tell us about you?
Yeah, I'm Gavin. I'm with Partnership for Children, and I coordinate a grant through the Strengthening Families Initiative called Project Welcome. And our focus is working with caregivers and mothers in the perinatal period, and specifically those struggling with substance use. So,
thank you. What about you, Caitlin?
Hi, I'm Caitlin Adamo, and I have a private practice providing telehealth I'm mostly working with moms, though I have some teens as well. And I'm a mom myself and survivor of PMAD myself, and just excited to be here with y'all.
Thank you.
I'm actually transitioning from Missoula to Livingston in the next month. Just to keep my network a little diverse.
Good. Hi, Stephanie.
Hello, everyone. I'm Stephanie Morton. I'm the program manager for Healthy Mothers, Healthy Babies.
Thank you. And hi, Megan. How are you?
Hi there. Sorry, I was running a couple minutes late. I'm Megan Fallon. I'm a therapist in Billings in a private practice. I work primarily with moms and a lot of young moms. I'm a perinatal mental health specialist. I just passed my certification a couple weeks ago. So thank you. So I'm official now, and yeah, I'm happy to be here, happy to help. I did have one quick question. Could I pop in for a second, Dr. Frieder? A couple weeks ago, we had staffed a case and somebody had given a recommendation for like an OB provider in the Missoula area. Does anyone remember who that was? Like who the doc was? I don't remember if it was an actual OB or maybe it was just like a general family practice who was pretty perinatal friendly.
I know I suggested Mariah Hill, who's a midwife.
Hill. Okay.
She's a midwife at Community Practice Group, Partner Group.
Okay, maybe that was it. Thank you very much.
I'm familiar with a lot of, doctors and OBs in Missoula. So if you want to talk about, we could talk privately too.
Okay. Yeah, I'll shoot you a message on here real quick.
Okay.
Cool, thanks. All right, thanks, Dr. Frieder.
Sure, this is great. It's interesting how many people that work in this field also have a history of going through PMADs. I think it gives you an extra level of sensitivity now and understanding what people are going through. So, okay, let me open my presentation. So today we are going to be talking about the management of anxiety and insomnia during the perinatal period. And please interrupt. You know, we are a small group, so you can interrupt me. If you have any questions, just tell me. It's totally fine. So any announcements? Anybody wants to say anything in particular? I think. Okay, I wanted to mention our consultation line. If you are not familiar with it, it's Present for Moms. It's a state-funded consultation line where you can call, or your providers can call, and we help them to figure out how to treat their perinatal cases. So please call us if you have cases that you need help with, or if you know any provider that needs help with our cases, perinatal cases, please tell them to call us. And you can submit by email, or you can call and we will return your call. So just to recap, perinatal mood and anxiety disorders are the #1 complication of pregnancy and childbirth. I'm sure everybody knows this by now, and its PMADs affect 1 in 7 pregnant and postpartum women. And I always like, when I talk to patients, because I'm going to talk about treatment, so I always like to talk to them about the risks of their symptoms and how it can affect their babies. So here you see a list of negative outcomes of pregnancy related to PMAD. So preterm delivery, low birth weight, small head circumference, low Apgar scores, postpartum depression, preeclampsia, severe forms of hyperemesis gravidarum, planned C-section, miscarriage, and increased admissions to the NICU. This is very important, actually, because a lot of women will be concerned that taking medications will increase the admissions to the NICU, but we know that actually PMADs can cause that. So that's important to keep in mind. And it's very important to let them know that if they are depressed or anxious during pregnancy, that puts them at a very high risk of postpartum depression. So that's important for them to know. So PMADs are associated with poor self-care, increased substance abuse, low participation in prenatal care. Also, it affects the relationship with the baby. There is disrupted attachment. There will be long-lasting neurodevelopmental effects on the child. The child can have behavioral problems later on. And as we spoke last time, avoidance of the child by the mother, how we can see in OCD or we can see in PTSD. So the ACOG recommends to screen for anxiety at least once during the perinatal period. And what we use generally to screen is the GAD-7. It's a very short questionnaire. The woman can do it herself, and you score it at the end, and it depends on how much it scores. You know if there is a risk of being anxious or not. So we are going to do a poll to see what people think and how people have been screening. How frequently are you screening for general anxiety disorders? So you can choose. Are people able to complete it? Okay. This is great. Almost everyone wants a trimester. This is really good. I should say that usually I'm getting more to use it now, but I used to just do a very thorough evaluation and not screen with screening tools, but I find them more and more useful actually, because it's just not helpful to see in the moment. It's also helpful, I think, to follow up and see if, like, how they evolve over time. So if you compare one trimester to the other, it's very helpful to see how much they score. So the other scale that we spoke about is the Edinburgh. And this one is really for depression. And it was done originally to use in the postnatal time, but now it's validated to use in pregnancy. And it's good because it also has some questions about anxiety. So it's like you can do it for depression, but if there answer some of the questions that are about anxiety, it can bring you some, you can think about, okay, this woman may be anxious. Like there is a question that says, I have been anxious or worried for no good reason. I have felt scared or panicky for not very good reason. So that is a red flag. It can bring up the thought on you that maybe this woman is anxious, and you can explore more that. So in terms of management, the goal is that the woman will feel well during pregnancy to improve the outcomes, and that it's important to let them know that no decision will be risk-free. And there is always a risk of the illness, and there is always a risk of the medications, and you need to individualize you put it in a balance and you see what's more risky, but it's individualized. You can't say this medication is the safest one. You need to say this medication is the safest one for this particular patient at this time. So it's a very individualized assessment. And you're always going to use medication with more reproductive safety data. So medications that are newer don't mean that they are safer. They mean that just we don't know enough about them. So it's always better to go with what you know more, even if you know there are some risks associated to it. And you will always try to simplify the medication regimen. So if a woman comes in 5 medications, you will try to diminish the amount of medications they take to the least amount possible, if it's possible. So you always will encourage the patient to participate in prenatal care, very important, and avoid like smoking, drinking, using drugs. Always involve significant other and the family in their care. It's also good to assess the situation. So I always try to bring somebody from the family who is the most important person in the patient's life to one of my appointments. So I can discuss the risks and the red flags, what they should look if there is a decompensation, but also to assess what's the situation, what is the woman dealing with in terms of dynamics in the family. Then you always need to discuss what are the goals of the treatment, what the woman wants. Very important to keep in mind what she wants. Help her reduce any stressors that are contributing to her symptoms. Optimize sleep, and we'll talk more about that. Optimize nutrition to help her feel better during pregnancy. And discuss the treatment options, and always include psychotherapy. And for some women, they will do well with groups. Some women will do well with individual. I always think that just giving medication, it's not the answer. You always need to associate it with a good psychotherapy. So we are going to talk about some medications that are specific for anxiety today and sleep. So in terms of breastfeeding, all the medications that we give in psychiatry pass and go to the breast milk. It's just that some do it in much less amounts than others. But what is important to know is that what the baby gets during nursing is much less than what they get during pregnancy. So really it doesn't make sense for a woman to say, oh no, I'm not going to breastfeed because of the medication when the baby was exposed the whole pregnancy. There are just few medications that I would say it's better not to breastfeed with, but most of them, I would say that if she was taking it during pregnancy, the amount the baby was exposed to is so much more than in nursing that it's okay to continue nursing. And the current guidelines really don't reflect the current data. So it's important to go to the literature and read what is known about it, because the new studies, the new research in the area, because what the American Association of Pediatrics or the physician desk references, it's not really what we use as the most up-to-date data. So there is no drug that is safest to use during pregnancy and the postpartum period or lactation. And we always make the decision based on the following: the history of the illness, the previous medication history, the severity of current illness, risk and benefits of treatment options, and patient's preferences. And this is very important because I get a lot of calls of doctors that just tell me, you know, oh, just 2 minutes, can you tell me if Zoloft is the medication of choice for this patient? And it's not that there is one medication that is the safest. It's just that for this woman, having in mind all these aspects, there will be one medication that is the best. So these are medications for anxiety. One second.
You cut out for a second, Dr. Frieder, but I could hear you just now.
Oh, can you hear me now?
Yeah, we can hear you again.
Yeah.
Oh, okay. It was saying, my screen was saying that I was muted, so I didn't know what was happening.
I think you muted yourself for a second, but you're back.
Oh, okay. Okay. So these are medications that we use for anxiety. So we have the most common ones that we use are the SSRIs. Then we have the SNRIs. The SSRIs are like what we call in the brand names, Zoloft, Celexa, Lexapro, Paxil, Prozac. Then the SNRIs, Cymbalta, Effexor, Restic. Then we have other medications that we also use, like Trazodone, Mirtazapine, that is Remeron. And then we have the tricyclic antidepressants that we use that are more the old ones, but we still use them, like nortriptyline, amitriptyline. And then the ones that I didn't include here are the MAOIs, that are medications that used to be used a long time ago, and now they are used for very resistant depression, but they are very risky to use in pregnancy. So I didn't really include them because of that. So the antidepressants are considered first line, like pharmacological treatment for anxiety during pregnancy. And as I said before, like you need to decide what you are going to use based on the history of the patient, what medications she used. So always, always, always try to use what previously worked. Even if it's something that is not what you think will be the safest in terms of like what has more data, but it's better to use what previously worked because that will work better now, most likely. If you try something new because it seems to be safer and it doesn't work, and then you have to try what previously worked, you are just going to expose the baby to 2 medications instead of just 1. So this is what I mean, like try to minimize switching medication during pregnancy. So try to go to what you know works. And always, yes?
So we do have a question in chat about, and Sarah Beth, do you want to just speak?
Sure. My question was, because I hear this with working with different Meadowlark sites and different care coordinators, that sometimes patients just want to stop medications altogether in the postpartum period. And do you recommend, like, is it ever safe for a birthing person to stop medication altogether, or do you always recommend they wean off medications?
So I would recommend not to stop, but if the woman wants to stop, that's her preference. I always would say to do it gradually. Like, we know that rapid stopping, like abrupt stopping, puts the woman at risk of a relapse, of having again symptoms in a faster way. So if you do it gradually, the symptoms, if they come back, they will come back in more gradual way and later on. And that's known. There are some studies showing that. So
that's helpful.
Yeah.
Thank you.
Yeah. So minimize changing medications. Always try to use one medication if you can, and the lowest effective dose, but this is very important. Use the effective dose, don't use just low because you don't want to expose the baby. Use what works because you need to make the woman feel better. So I always tell the patient that you want to minimize exposures. So if you are giving them a very low dose, you are just exposing the baby to two things, the mental illness and the medication. But if you give a good dose and the woman is doing better, you are just exposing the baby to the medication and not to the mental illness. So that's why you use the lowest effective dose. You always try to discourage stopping medications prior to delivery. This is very important because SSRIs and SNRIs were associated are associated with what we call adaptation syndrome. That means that 15% of babies can have like a transitory syndrome for at the most 1 week, where they are more colicky, irritable, breathing faster. They might need to be observed for a few days. And so when in the literature, when they realized that this was happening, they said we have to stop medications in the last months of pregnancy. But that puts the woman at risk of having a postpartum episode of depression or anxiety or whatever is her psychiatric condition. So now, and there are also studies now that show that actually stopping the medication at the end, like before the last month of pregnancy, doesn't prevent the adaptation syndrome from happening. So it doesn't really help with adaptation syndrome, and at the same time, it puts the woman at risk of postpartum depression. So it doesn't really make sense to stop medications prior to delivery. And you will need to adjust medications as pregnancy progresses because the volume of distribution, the metabolism is faster, and women might need higher doses as the pregnancy progresses. So as I said before, no decision will be perfect or risk-free. SSRIs are among the best studied class of medications during pregnancy. This is very reassuring, actually. And both, you always need to consider medications and non-medications options when you are thinking about a treatment. And as I said before, you will always try to use psychotherapy or other kind of non-medications if possible for women as an adjunct, or just if it's a mild case as the first step. So in terms of the risk of antidepressants, there are some studies that suggest that there is a small risk of malformations with SSRIs, particularly with paroxetine. If you read the literature very well and you really read the studies that are done well, you will see that actually the risk of birth defect is not more than in the general population. So that's very important. Every person, every woman that gets pregnant has a risk of malformations. And the risk with SSRI is not higher than in the general population, even with paroxetine. They did studies and they saw that it's not as risky as they thought. Still, the FDA classified as class D, which means that you have to be careful and not give it. But if you read the literature, it's not as bad as we used to think. And most of the evidence doesn't suggest there are birth complications with these medications. And the studies don't suggest there are long-term neurobehavioral effects on children. And what I was talking just right now about the adaptation syndrome, that's what they call here the transient neonatal symptoms. That you will see. I don't see it very frequently. I actually see it very infrequently, but you can see that. In terms of breastfeeding, the SSRIs and the SNRIs are the first line agents. What is very important in breastfeeding is that the woman wants something that is non-sedating. She doesn't want to fall asleep while she has a newborn, and you don't want them to fall asleep with a newborn, you know? So that's good about these medications. So they are non-sedating, they are well tolerated, and they're very good for anxiety and obsessive symptoms. And both sertraline and paroxetine have very, very low levels on the infant serum level and in breast milk. In breast milk, they are so low that with some tests, they are undetectable. Some studies suggest that they can have some adverse effects like increased crying, decreased sleep, GI distress, irritability. But the reality is that babies tolerate them very well. With the ones that there are more reports that can have a more adverse effect in terms for the baby is fluoxetine, Prozac. But this is based in case reports, and it's not like a very severe effect. It's this kind of effect that I'm mentioning here. And there's no a lot of data in terms of long-term neurobehavioral effects in the children that were exposed during breastfeeding to these medications. But the small studies that we have don't seem to show any negative effects. So the other medications we use for anxiety are these ones, are the benzodiazepines. And they might sound familiar because a lot of patients take them. So alprazolam or Xanax, oxazepam we don't use much. In psychiatry, lorazepam, Ativan, diazepam, Valium, clonazepam, clonopin, and chlordiazepoxide, Librium we use for alcohol withdrawal. So the benzodiazepines are used both for perinatal depression and anxiety. They help a lot with symptoms of anxiety, rumination, and inability to fall asleep. And usually what you do, you combine it with an SSRI, and these medications you give them for a short period of time until the SSRI starts working. So they are not meant to be long-term. They are meant to be used until the SSRI starts working, because the SSRI can take 2, 3, or even 4 weeks to start working. So you don't want the woman to be suffering all that time. So you might use these medications to help in the meanwhile. Initially, there were some reports that these medications can cause oral cleft and palate, but more recent reports, better done and bigger reports, don't suggest that that's an issue. But if you take all the information we have and you put it together, the risk of oral cleft is 11 in 10,000 compared to 6 in 10,000 in the general population. So if you want to be very careful, you can avoid this by minimizing its use between the weeks that the oral cleft and palate, the lip and palate are formed. The thing that you need to be more careful with these medications is when the baby is going to be born, because if the woman is at a higher dose of these medications, the baby can be born with withdrawal or toxicity. And this can be manifested as hypotonicity, failure to feed, apnea, low Apgar scores. In some studies, they suggest floppy infant syndrome. So you avoid this by slowly tapering the medication before labor. So in breastfeeding, you will always try to use the ones that have a shorter half-life and have no active metabolites, because they are found in lower concentrations in the breast milk. The ones that have longer half-lives, like diazepam, they tend to accumulate in breast milk. And there were some case reports that suggest that diazepam was found to have central nervous system depressant effects in nursing infants. So that's important to know. So non-pharmacological options, psychotherapy, like CBT, meditation, mindfulness, progressive muscle relaxation, yoga, acupuncture, exercise. Very important, support the mother on feeding preferences. I think this is a source of anxiety for a lot of women. How are they going to feed the baby? And in their particular culture or a circle, there might be a strong feeling that they should feed in a certain way. And if they don't agree with that way, they might get anxious. So if you can support a woman on her decision and help her communicate this to the family, I think it's very important. And very important, make sure that the woman sleeps mostly in the postpartum, but also during pregnancy. I had women come in with anxiety because they couldn't sleep, and we'll talk more about sleep in a little bit. But when they can't sleep, they get more anxious. And then if they get more anxious, they can't sleep. And it's a cycle that you have to break because it's not helpful. It can get them into a depressive episode too. So in terms of insomnia, so it's very common, during pregnancy. More than 60% of women have difficulty sleeping during pregnancy. And 15 to 80% of women report sleeping problems during the first trimester, and 66 to 97% of women in the third trimester. And it can be for different reasons, and we'll talk more about that. So insomnia is a major risk factor for postpartum depression and postpartum anxiety. So always, always, always ask about sleep. So when you have somebody with insomnia, you have to figure out what's the reason and help them with certain tools and treatments. So first, you are going to rule out that there's no underlying medical reason for the insomnia. And it can be sleep apnea. It's very common in pregnancy, restless leg syndrome. And restless leg syndrome can be associated to anemia. So you have to ask them, what is the reason? What are the symptoms she has? Why she can't sleep? Also, thyroid dysfunction can give insomnia. And then psychiatric causes. Depression, anxiety, mania, what is the reason for the insomnia? And we are going to talk about this in a little bit, the other things. So first of all, the first thing you want to do is sleep hygiene. Like I'm sure you know about this. So make sure the woman keeps the room dark and cool, limits screen time, minimizes caffeine and alcohol. It's not watching the clock constantly. Use the bedroom only for sleep and sex. Get out of bed if unable to fall asleep, and has a regular sleep schedule when possible. So this is very important, and this is the first measure that you are going to take when somebody can't sleep. So the treatment that has most effectiveness for sleep is CBTI, cognitive behavioral therapy for insomnia. And it's really amazing. And I don't know if you have experience with it, and I would like to ask all of you if you know about it, because the patients that I send for CBTI, it's not just that it helps them to fall asleep in the short-term period. They gain tools for the long-term period. So then they are able to, if they have a period where they have insomnia, they can get back to fall asleep without any help and without medications. So this has been really, really helpful. So it consists of sleep hygiene, stimulus control, sleep restriction, cognitive therapy, and relaxation training. So it's a combination of all these. So you are going to help them restructure their thinking, because when they can't sleep, they have negative thoughts about their sleep and about the things that make them not being able to sleep. You are going to make them initially sleep certain amount of hours, even if it seems that is a short period of time, but that's the time they should sleep. You are going to make sure they are in bed just for sleep. And if they are more than 10 minutes in bed that they can't sleep, they should get out and do something else. And then this treatment, and you are going to teach them relaxation techniques, you know, so they can have their own tools to make themselves fall asleep. And what is good about CBTI is that it's a short treatment. It's 6 to 8 sessions. So it's not something that you do in the long run. It's very, very helpful. And more for a woman that is pregnant or postpartum, if she wants to avoid medications, this is really a good option. So other treatments, other non-pharmacological options that can help are meditation, mindfulness, progressive muscle relaxation, yoga, acupuncture, exercise. It's the same that for anxiety, some of them. It is recommended by the ACOG that women that are pregnant exercise every day for 20 to 30 minutes. And in the postpartum, when they start feeling better physically, they start exercising again. So it depends on the woman. You have to tailor your relaxation techniques to this specific woman, but these techniques all can be helpful. So in terms of medications, it's very tricky in the postpartum. During pregnancy, you can use antidepressants that are more sedatives, like the tricyclics that we didn't talk before much, that are older antidepressants, like nortriptyline, amitriptyline. And we use them in these kind of situations at low doses. They seem to be very safe in pregnancy. The problem is the side effects they have. So some women might not tolerate it because they increase dry mouth, constipation. You have to make sure they don't have heart problems. So there are medications a little bit more difficult, not difficult, but you have to keep an eye on the patient. The other ones that I use for sleep is mirtazapine and trazodone, that are antidepressants that are sedating. And they seem to be okay. We have less information than the SSRIs in pregnancy, but the information we have so far, it's safe. So we use them in pregnancy. The sedative hypnotics like Lunesta, Ambien, and those have limited safety data. So I usually don't give them because I'm more concerned about them. The other medications that we use for sleep are benzodiazepines like Ativan, clonazepam. I like Ativan a lot, lorazepam, because it passes the placenta less from all the benzodiazepines, and it has no active metabolites and is short acting. So I usually give that. The other medications that I didn't put here and are very good for sleep in pregnancy are the antihistaminics like Benadryl, doxylamine. Those ones we use for sleep in pregnancy, and they are safe and very effective. The one that I don't recommend, and some people think it's okay because it's natural, it's melatonin. Melatonin, you like melatonin, Caitlin? Oh, okay.
I'm glad you're talking about this because I am always talking to people about this. Like melatonin is a hormone, and just because we can get it over the counter doesn't mean that we should just use it like candy. And so I'm curious because I'm curious about the pregnancy period, if there's any contraindications, but I'm often, kind of telling people who aren't in that phase of life, what about magnesium, as it is a mineral that we're often all depleted in. What are your thoughts on that?
So let me tell you first about melatonin, and I'll talk about magnesium too. So in terms of what I wanted to say about melatonin is that it can affect the circadian rhythm of the baby when the mother is taking it in pregnancy. So you have to be careful with that. And in animal studies, it seems that the pups have a higher rate of mortality when they are exposed to melatonin. There is not enough data in humans, so I usually don't use it. And in breastfeeding, it can change the taste of the breast milk. So that's very important. In terms of magnesium, I like it a lot because it's very calming, and it's good for relaxation and to help people to sleep. The problem with magnesium, it's hard to measure how much you have in your blood, and usually you have to measure how much is in the red blood cells, and sometimes it's not even accurate. So I try to be very careful with these things, but for some people that I think might benefit from it, usually I don't use it in pregnancy, because in pregnancy, you don't really know. Some of the supplements in particular and minerals are not regulated, and you don't know what other things they have and what is the actual dose that the patient needs, so it might not be what comes in the bottle. So I'm very careful in pregnancy. So I think this is it. Any questions?
I have a question about the use of Seroquel.
Oh yes, that's a great question. So let me stop sharing my screen so I can see you all. So Seroquel, it's an antipsychotic that we use as a mood stabilizer for bipolar disorder too. But the good thing about Seroquel is that it's really good for anxiety and it's sedating. So at low doses, we use it also for sleep and for anxiety. So I should say that in some instances, I use it for sleep in pregnancy, because it might be like, I will give you an example. Last week, I saw a patient who was very anxious, extremely anxious and depressed. And she was started on Zoloft by her prior psychiatrist, which was great, but she was still very anxious. And she was in the first trimester, and she was at the time of the formation of the lip and palate. So I was like, what do I do? Do I give her a benzo now? And I thought, maybe it's better to wait a few weeks for the benzo, and maybe if the SSRI works, she won't need the benzo. So I thought Seroquel is a great option for this woman, like to make her sleep, to take away the anxiety, and to help in the meanwhile at a low dose. And it really, really helped her to calm down the anxiety. You give her the minimum dose. It's very safe in pregnancy. It's from all those antipsychotics, it's the one that passes less the placenta. So that's really reassuring. The only thing you have to be careful with Seroquel is the metabolic effect. You have to monitor for the glucose, the cholesterol, and make sure that everything is okay, because the woman can be at risk of gestational diabetes. So you have to keep an eye on them. But that's a great thought. I actually forgot about Seroquel when I wrote the slides. Thank you.
Dr. Frieder, can you speak to the need to maybe increase medications during pregnancy? Do women find that as their body changes and blood volume changes, that med dosage needs to change, even if they were being treated effectively at a lower dose?
Yes, so that's something that I always tell patients when they come first, because I don't want them to be surprised later on that they have symptoms or that they need a higher dose of medication. They might feel like kind of surprised with the situation. So it depends on the medication, but there are medications that because of the volume of distribution, you need higher doses as the pregnancy progresses, you know. Then there are medications because of the metabolism, like Lamictal, you might need higher doses as the pregnancy progresses, you know, or also with lithium, you need higher doses as the pregnancy progresses. So what I do usually is I monitor them closely. And if there are any symptom, you know, even little symptom that makes me think I need to do something, I increase the medication. And what is important, yeah.
Well, I was just going to say, so actually I was meeting with a client right before this call today, and she just hit her second trimester. She's at 15 weeks. She's been treated with 100 milligrams of sertraline for a really long time and has been really well managed, but her depression is like full force right now. And so I told her to call her provider because I didn't know if that would be appropriate to look at an increase at this point.
Totally.
Okay.
Yeah, very much.
Thank you.
Yeah, and what happens is that sometimes in pregnancy, you end up using doses that are higher than what we use in the general population, you know? So like now I have a patient on sertraline, she's on 300. Like usually I never use those doses, you know? I never go so high, but she was in 200 when she started the pregnancy and she's having symptoms. So we said, and she had, you know, for OCD, you need higher doses and she has OCD. So we said, let's try to increase it a little bit more before we say, no, let's try something else. But she had such a good response to sertraline that I didn't want to change it.
Yeah, and that's interesting because this client actually has an OCD diagnosis as well. So
usually they need higher doses.
That makes sense. Thank you.
Yeah, sure. Anyone has a case that they want to discuss or any questions?
Can I ask a question kind of going back to your lecture today? When you're, you know, we're asking about like screening clients, you know, and how often you're screening for, part of me is, and I don't know if, you know, we're all kind of like diverse in our roles.
Yeah.
And so, you know, I'm thinking like, well, when I get a client, you know, I'm really just doing some initial assessment and screening, and every session is a new assessment to some degree, like constantly reassessing. You know, so, you know, I'm thinking about like, I'm just kind of I always kind of come back to like this like dance right now with like accuracy of diagnosis and like, and it's hard for me because I'm not generally very medical model kind of therapist. And so to me, it doesn't change a whole lot of my treatment. Like I'm still using similar modalities, similar interventions. And yet, so, you know, these first couple of sessions at the initial time, you know, I'm, you know, really seeing criteria for like an unspecified anxiety disorder or something. And then like session 3 comes in and it's very clear, oh no, we're also having little or no interest in things and feeling chronically depressed too. And so I'm just, you know, I'm always seeing that overlap of anxiety and depression. And I get so annoyed to some degree with like how separate they are when they're best friends, you know, and they always hang out together. And so it's like, okay, what's really dominating their nervous system? You know, are they really staying in that parasympathetic zone or more of that sympathetic zone? Is that what I'm, you know, really kind of isolating? Because a lot of times they're identifying all of these things, you know, if I gave them the GAD or if I gave them just, you know, just those 2 questions for depression, you know, they'd validate all of it, you know. And so then is it like, you know, anxiety and depression. And I don't know, it's just like, the nuances of depression. I don't know if the others experience that.
I think it's a great point, because I think they go together so much, you know, depression and anxiety, and it's hard to separate them many, many times. Like it's just really an issue of writing a diagnosis, but many times they really, most of the times they go together, you know? So, and in terms of like the screening, like I agree with you. When I see somebody every week, I'm not screening them. Like I'm screening them in my own way, you know? I'm evaluating them every week. I'm talking to them, and I know how their anxiety is, and I know how their depression is by the conversation I have with them. So in those kind of instances, I might not use these scales, you know. I think that's more important for obese, you know, for that kind of.
To get them to the care that they need, right?
Yeah. Or if you want to use it like when I used to work in a hospital, what we used to do with the EPDS, the Edinburgh, is like a way, like we used to do it every time we saw the patient, or at least once a month, so we can follow, like a way of following and seeing how they were getting better, to have an objective measure of how they were getting better, you know? So it's not just your words saying they are getting better, but you have an objective measure too. Any cases? Anyone wants to talk about a patient? I have a very complicated case that I don't know what to do. I can share.
Yeah, let's hear it.
She's not pregnant yet, you know, but she has a lot of anxiety and a history of depression. She actually had trauma when she was 1 year old. So she doesn't remember the trauma, but I'm pretty sure it's there, you know, it's really affecting her. And her anxiety is so big, she can't sleep. She's so anxious that she tries so many. She really is amazing because she does yoga, she does meditation, she does tapping at night. She tried all the supplements you can imagine to help her. And she is in a lot of medication. She came to me in like a big amount of medications for anxiety and sleep. So she's on a medication called gabapentin. That is an anticonvulsant, but we use it a lot for anxiety in psychiatry. She also takes alprazolam, that is a benzo, it's Xanax. She also takes now, she takes Valium, that is diazepam. It's the long-acting benzodiazepine, you know, so which we don't really want to use in pregnancy. She has a social anxiety, so she takes propanolol, that is good for performance anxiety when you are in those situations. And what else she takes? I think that's it, and that's a lot.
Yeah, how would she?
What is it?
That's a lot.
So it's not just it's a lot, it's that it's a lot of medications that we don't know enough in pregnancy, you know, and she wants to get pregnant. So I'm trying to figure out how to help her. But we tried, I have been seeing her for a year now. And we try to get her off medications, you know, to make it better so she can take less medication so she can get pregnant. But the reality is that every time we decrease something, yeah, her thyroid is okay. She's very good at going to the doctor. Everything is okay physically. So every time we try to go down on the Valium, on the diazepam a little bit, she gets so anxious at night, she can't sleep. The other medication she takes is mirtazapine, Remeron, that helps her to sleep and helps the anxiety and depression. So every time I try to take something out, she gets so anxious and she can't sleep. So
how long did you?
Yeah.
Can I ask how long you've been seeing her?
1 year.
1 year. And she's doing psychotherapy with you as well?
No, she has a psychotherapist. It took time to get her to psychotherapy, I should say.
Yeah, so I just start wondering if there's like an underlying trauma history.
There is.
Yeah.
And I also wonder.
Yeah.
I was just gonna say, are there any safety issues at home?
No, she lives with her husband, who is very supportive. But she has a trauma history. She's from another country, and when she was born, there was war in the other country, and they were in a shelter underground for 2 years. And her mother was very depressed at the time, and they had to flee the other country to come to the US. So I think that really had an effect on her, even though she can't remember it. You can imagine that's a big trauma. So, but it's hard because she has no recollection of it. How do you, I guess that's my question to you. You might know more about it. How do you work with it, when somebody
I would
has no
work with
recollection?
her body. I mean, it sounds to me like, she's so in her head. She needs a kind of therapy that's going right into her body and doing the body work, because that's what's going to uncover some of those sensations. And then, maybe we're bridging some conscious connection eventually. And she's working on that. She's working on that in her yoga. I mean, she's starting to really trying to integrate as much as possible. And there's obviously some deep work there that's like, influencing those symptoms. So I just think about, does she have that web of support to really start doing that in-depth attachment work that's really in her body? It's like, that's so such a I think about sensory motor psychotherapy, and I think about, somatic experiencing. But both of those are modalities that really, really focus on going in the body. And it's so easy in talk therapy to just go straight to the cerebral stuff. But I just think about that with her.
That's a great point.
And then I also wonder, kind of to piggyback off what Caitlin said, EMDR, therapy, eye movement, desensitization, reprocessing therapy. She doesn't have any recollection of any kind of trauma, but I can imagine the stories that she's heard, growing up. And especially, especially like you think about, first memories at 4 or 5, the family was still in a trauma state at that point. And so being able to connect the sensations she's currently experiencing with the body, but also what are the negative cognitions she believes about herself related to what she's been told about the trauma, and starting to reprocess that could maybe push. Because I can imagine, she doesn't have memory of being in the shelter and being underground, but she has memories of when she came to the States. Yeah. And I can imagine, immigrating to the States from a war-torn country. I mean, that's traumatizing in and of itself, let alone all the stuff she happened beforehand.
Yeah, that's right. Thank you.
I'd add to that, just like throughout her childhood, and I mean, doubtlessly her parents also experienced some of those traumas, and being raised by parents with PTSD is almost traumatic within and of itself. And just kind of hearing those stories and working with those through her psychotherapy, I think could be really valuable as well.
I agree. Totally. I wanted to answer Cassie's question in the chat. She tried so many medications before. She even tried barbiturates, She tried Diospar effects or everything you can imagine. This is the regimen that works the best for her. So I'm a little bit concerned about changing it now. But thank you, everyone. It's 3 p.m., so I'm sure people have to go. It was really nice to see you and talk to you.
Thanks, you.
Thank you. And hey, Caitlin, I sent you an email.
Oh, fantastic. Thanks, Megan. I look forward to connecting.
Okay, bye, guys.
And we'll see you in 2 weeks.